Corneal ulcer. Introduction. A corneal ulcer is an open sore or epithelial defect on the cornea, often accompanied by underlying inflammation or infection. It is a medical emergency due to its potential to cause severe pain, vision loss, or corneal perforation if untreated. Corneal ulcers are commonly linked to infections, trauma, or contact lens misuse and are more prevalent in areas with limited access to eye care. Early intervention is essential to prevent permanent damage and restore ocular health. Definitions. A corneal ulcer is a loss of corneal epithelium with underlying stromal involvement, typically caused by infection or injury, leading to pain and potential scarring. An acute condition involving corneal tissue breakdown, often infectious in origin, posing a significant risk of blindness in underserved populations. Risk factors. Infectious factors. Bacterial infection, example Pseudomonas aeruginosa, Staphylococcus aureus. Fungal infection, example Fusarium, Aspergillus. Viral infection, example herpes simplex virus. Parasitic infection, example Acanthamoeba. Non-infectious factors. Contact lens overwear or improper cleaning. Eye trauma, example scratches, foreign bodies. Chronic dry eye or eyelid abnormalities, example blepharitis. Autoimmune conditions, example rheumatoid arthritis. Environmental and lifestyle factors. Exposure to contaminated water or soil. Poor hygiene, example unwashed hands, reused lenses. Occupational hazards, example agriculture, construction. Use of contaminated or expired eye drops. Tropical or humid climates, favoring microbial growth. Etiology. Corneal ulcers are classified based on their underlying causes. Infectious ulcers result from bacterial, fungal, viral, or parasitic invasion of the cornea. Non-infectious ulcers stem from sterile trauma, chemical burns, or neurotrophic factors, example nerve damage. Secondary ulcers occur as complications of pre-existing conditions like keratitis or severe dry eye. Types. Bacterial corneal ulcer, rapidly progressive, often linked to contact lens use. Fungal corneal ulcer, slow-growing, common after vegetative trauma, example plant scratches. Viral corneal ulcer, recurrent, typically herpes-related with dendritic patterns. Acanthamoeba corneal ulcer, severe, resistant, associated with water exposure. Neurotrophic ulcer, non-infectious, due to corneal nerve dysfunction. Pathophysiology. Corneal injury or infection. Trauma or microbes breach the epithelial barrier. Down arrow. Inflammatory cascade. Cytokines and neutrophils infiltrate, causing tissue breakdown. Down arrow. Stromal degradation. Microbial enzymes or immune response erode corneal layers. Down arrow. Ulcer formation. Visible defect with stromal loss and opacity. Down arrow. Potential scarring or perforation. Healing with fibrosis or rupture if untreated. Down arrow. Vision compromise. Opacity or irregular astigmatism impairs sight. Clinical manifestations. Intense eye pain, often disproportionate to visible signs. Redness and conjunctival injection. Excessive tearing or purulent discharge. Foreign body sensation or grittiness. Blurred or hazy vision. Photophobia, light sensitivity. Visible white or gray spot on the cornea. Eyelid swelling or difficulty opening the eye. Reduced visual acuity. Diagnostic evaluation. History taking. Onset and progression of symptoms. Recent trauma, contact lens use, or environmental exposure. History of ocular infections or systemic diseases. Physical examination. Slit lamp examination to assess ulcer size, depth, and infiltration. Fluorescein staining to highlight epithelial defects and ulcer margins. visual acuity testing to evaluate functional impact. Laboratory and imaging tests. Corneal scraping for culture, bacteria, fungi, parasites. PCR testing for viral etiology, example HSV. Confocal microscopy for acanthamoeba detection. Medical management. Pharmacological management. Antibiotic drops, fortified drops, example tobramycin, vancomycin, for bacterial ulcers. Antifungal drops, natamycin or voriconazole for fungal ulcers. Antiviral therapy, acyclovir, topical/oral, for viral ulcers. Antiparasitic drops, PHMB or chlorhexidine for acanthamoeba. Cycloplegic drops, cyclopentolate to reduce pain and ciliary spasm. Steroids, limited use post-infection control to minimize scarring. Surgical management. Corneal debridement, removal of necrotic tissue to enhance drug penetration. Therapeutic bandage contact lens, to promote healing in non-infectious cases. Corneal transplant, for perforation or extensive scarring. Dietary management. Vitamin A, example leafy greens, carrots to support epithelial healing. Hydration, to maintain tear film and corneal moisture. Omega-3 fatty acids, example fish, flaxseed to reduce inflammation. Nursing management. Risk for infection related to microbial invasion or poor hygiene. Interventions. Educate on strict contact lens hygiene and discontinuation during treatment. Administer antimicrobial drops as prescribed, ensuring correct frequency. Teach hand washing before eye contact or medication application. Advise against touching or rubbing the affected eye. Monitor for worsening discharge or spread of infection. Risk for vision loss related to corneal scarring or perforation. Interventions. Assess and document visual acuity changes regularly. Educate on treatment adherence to prevent permanent damage. Encourage timely follow UPS with an ophthalmologist. Teach recognition of emergency signs, example sudden vision drop. Recommend protective eyewear during recovery. Impaired comfort related to severe pain and photophobia. Interventions. Administer cycloplegic drops to alleviate pain and spasms. Suggests sunglasses or dim lighting to reduce light sensitivity. Apply cool compresses to soothe irritation. Encourage rest with eyes closed to minimize discomfort. Provide prescribed analgesics for pain relief if needed. Risk for corneal perforation related to progressive ulceration. Interventions. Monitor for signs of perforation, example sudden pain increase, aqueous leak. Educate on urgency of reporting worsening symptoms. Prepare for surgical referral if perforation is suspected. Ensure strict compliance with antimicrobial therapy. Advise against eye pressure or trauma during healing. Disturbed body image related to visible corneal opacity or redness. Interventions. Reassure about treatment potential to reduce scarring. Discuss options like tinted lenses or surgery for cosmetic restoration. Offer emotional support for concerns about eye appearance. Encourage discussion of feelings about vision changes. Refer to counseling if self-esteem is significantly affected. Prevention. Contact lens hygiene, clean, store, and replace lenses properly, avoid overnight wear. Eye protection, use safety goggles for hazardous activities or sports. Avoid contamination, do not use tap water with lenses or touch eyes with dirty hands. Prompt treatment, seek care for eye injuries or infections immediately. Regular exams, screen for early signs in high-risk individuals, example lens users. UV protection, wear sunglasses to prevent secondary damage. Complications. Corneal scarring or opacity. Permanent vision impairment. Corneal perforation or melding. Secondary infections, example endophthalmitis. Chronic pain or recurrent ulcers. Irregular astigmatism. Conclusion. Corneal ulcers represent a critical ocular condition requiring urgent attention due to their rapid progression and sight-threatening potential. Caused by a range of infectious and non-infectious factors, they demand tailored treatment and vigilant prevention, particularly among contact lens users and trauma-prone individuals. Through timely medical intervention, surgical options when necessary, and patient education, the risk of complications can be minimized, preserving vision and quality of life.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.